Just 17 seconds left.
Okay.
Right. So if you have read and understood, considering it critical care scenario, kindly please tell me how would you manage this patient?
Okay, I will manage the patient according to critical care of critical ill surgical patient.
Yes.
I will start by securing the airway,
Yes.
and then check the patient can speak, and then breathing, and I will give the patient high flow oxygen, and then I will go for the circulation. I will assess the vital, blood pressure, pulse, and capillary fill time, and also I will insert two large bore cannula, and I will insert catheter, and
Okay.
then I will start resuscitate the patient by give the patient fluid, crystalloid, and give the patient painkiller, and after stabilize and
Considering, yes, good, thank you. Considering this time, what is the provisional diagnosis that you consider helping
okay,
the patient
according
with?
to the scenario, it is most probably obstructive jaundice,
Okay. Why do you
because
think urobilinogen is not detectable in urine?
because there is obstruction of the bile duct.
Okay.
So the bilirubin cannot reach the intestine, so cannot detect it in the urine.
What might be the normal level of bilirubin?
I think from 0.3 to 1. Could it remember? 230.
Tell me direct how much it should be and total.
Okay, okay. The
Yeah.
total less than 30, and the direct.
Normal, okay, less than 30, right. Okay, we'll move on. Can you tell me what type of bilirubin is found in blood?
Okay, we found the pounding bilirubin, like urobilirubin, and also small amount uh, of uh, conjugated bilirubin, and
Can you please tell me the process of bilirubin metabolism?
okay, when the end of the life of RBCs and the spleen lead to destruction of these RBCs, it will be like the hemoglobin divided to globin and heme, and the heme will be converted to bilirubin, and release the the iron, and bilirubin then converted to bilirubin. It is water insoluble. Then it is bound to protein albumin till reaches the liver sinusoid, and then releasing from albumin entering the liver sinusoid. Then in hepatocyte will converted this bilirubin, unconjugated bilirubin will be conjugated by glycuronic acid by the enzyme of glycuronyl transferase to conjugated bilirubin. It is now water soluble, direct bilirubin. Then it will be moved with the bile to the intestine.
Can you please tell me what is starcobilin?
What again? The question?
Starcobilin.
Starcobilin is the oxidative part of bilirubin go in the feces.
Okay, good. All right. Can you tell me, right, what are bile salts?
Bile salt, it is important in the lipid metabolism, lead to emulsification of the fat to small pieces like measles, to enhance increase the surface area in the small intestine, to allow the pancreatic enzyme, the lipase, to absorb
Okay.
the lipid.
Can you give examples of primary bile salts and then secondary bile salts? How would you classify them?
Actually, I don't know the answer.
Okay, we can come back to that later.
Mhm.
All right. Can you tell me, out of all these labs, which you can see here, which lab is most important? Like, will be a worrying for you that why this patient has this lab deranged or raised.
Okay. Alkaline phosphatase, because it is
Okay, yeah, because
increasing from it is releasing from epithelium of bile canaliculi of the epithelium of the gallbladder or the
okay,
bile duct, sorry.
okay,
So it is increasingly increasing give us clue it is from obstructive from the bile right itself, right or wrong?
okay. All right, okay. We can consider that. All right. What should be the ultimate management of this patient if you consider it to be obstructive jaundice?
Okay, I will treat according to the cause. If
You-
the cause is obstructed from inside or from
Yes.
pressure outside, if it is the cause like stone, I will go for ERCB for
Okay.
drainage of the stone and put it the stent. And if it is the cause like pancreatic cancer, then can go for
Stenting to relieve.
histology and pathology. Yeah.
Okay, or
Uh,
maybe the stenting to relieve the obstruction because
yeah. Okay. Yeah.
depends if you can operate the patient or not. Okay. Just suppose, right. You told me, right. In this patient, what clotting abnormalities do you expect to see because of obstructive jaundice?
Uh, I think it is will be like coagulopathy due to liver infection, lead to affect the fat soluble vitamins like vitamin A and D and K, and thus led to vitamin K. It is important to synthesis and of 2 and 7 and 9 and 10 clotting factor.
Okay.
So
Other
and
than
will
vitamin
be
K,
affected.
what
Mhm.
else can you give to correct clotting abnormality?
I can give fresh frozen plasma
Right. What
and
is prothrombin complex concentrate?
factor 2.
Are you telling me or asking me? All right. Can
Telling
you tell me how
what
would you
right or
classify
wrong.
jaundice? How
Okay,
would you
jaundice
classify? Yes.
can classify it is like a pre-hepatic or hepatic or post-hepatic.
Yes. Obstructive
Pre-
jaundice is which type of jaundice?
post-hepatic.
Very good. Other than gallstones, what else can cause post-hepatic or obstructive jaundice?
Tumor of the head of the pancreas, or
Both?
maybe tumor of the common bile duct, choledicopancreatic cancer,
Have you heard
and
of the term?
lymph node
Yes.
also enlargement,
Yes. And
and
if it's
extrahepatic cause,
yes.
maybe duodenal cancer.
All right. Okay. Bell is gone. But one last question. I want you to consider or think if it is cholangitis. Okay.
Okay.
Then
Mhm.
which medications or antibiotics would you give to the patient?
I will give the patient third generation cephalosporin,
According to the
and
trust
I will
guidelines.
drain.
According to
According to the trust guideline, and after take a consultation from microbiology, take a culture first, and then go for broad spectrum antibiotic to cover positive and negative and anaerobe, and drainage of decompensated this bile duct to relieve the infection and relieve the symptoms.
yes. Good.
And what else? I think that's good.
Yeah. Good. Thanks. Thank you.
Mom, tell me what this primary and secondary bile